The topic of today's discussion is bronchial asthma. What is asthma? So, it is an episodic reversible constriction of lungs or tracheobronchial tree due to its hyperactivity towards variety of stimulus. Okay, so it is an obstructive lung disease. So, as you guys know that there are two types of obstructive lung diseases. One is asthma and second one is COPD. But the difference between asthma and COPD is that asthma constriction is irreversible, and in COPD constriction of tracheobronchial tree is irreversible. There are two types of asthma. One is extrinsic and the second one is intrinsic. Extrinsic asthma is due to some external allergens that can be dust, pollen, fungal spores, that can be occupational asthma, that can be domestic due to some soft furnishing, carpets, curtains, sofa, blanket, etc. And on the other hand, intrinsic asthma is due to autonomic dysfunction that can be due to some kind of injury or ischemia or trauma to hypothalamus. As a result, there is parasympathetic overdrive, and that parasympathetic system causes bronchoconstriction. So in intrinsic asthma there is autonomic dysfunction and parasympathetic overdrive that as a result causes bronchoconstriction. So asthma that improves on weekends and worsens on weekdays is occupational asthma. Let's study extrinsic asthma in detail. So if we see the etiology of extrinsic asthma, there is an epidemiological triad. So in this triad there are three things: agent, that can be allergen, that must be allergen, I must say, and that can be host, and third thing is environment, and environment should support allergen. So when we see pathogenesis of asthma, there are two phases. One is initial phase and the second one is late phase. Initial phase, when we see dust or any other kind of allergen is taken as antigen. So antigen is presented to antigen presenting cell or macrophages. Helper T lymphocytes releases cytokines that goes to B lymphocytes, and B lymphocyte, you all know, produces immunoglobulins. And in case of asthma, immunoglobulins that are produced is IgE. IgE binds with mast cells, and when upon re-exposure of allergen, cross-linking of this immunoglobulin or this IgE takes place, and as a result mast cell that is filled with histamine ruptures, and when mast cell ruptures there is a huge release of histamine. So when histamine is released in the body, there are certain functions that it does to body. One is bronchoconstriction, second one, it increases bronchial gland secretion, it causes vasodilation, and it increases vascular permeability. Usually this whole thing starts within 5 minutes of exposure to allergen and ends within 60 minutes. So the whole initial phase ends within 60 minutes. Why it ends within 60 minutes? Because this histamine is degraded by an enzyme that is called histaminase. So that's why there is no role of antihistamine in case of bronchial asthma. That was initial phase, and let's come towards late phase starts within 2 to 8 hours, and it can continue up to hours, days and weeks. So this histamine that was released by the rupture of mast cell, what does it do? In late phase it activates phospholipase A2. So phospholipase A2 breaks down arachidonic acid. Okay, so arachidonic acid, when it is broken down, it moves towards two pathways. One is lipoxygenase pathway and the second one is cyclooxygenase pathway. In lipoxygenase pathway, there are certain leukotrienes that are being produced. One is leukotriene B4 that helps in chemostasis of WBCs, and the second one are SRSA, that is slow releasing substance of anaphylaxis, that is leukotriene C4, D4 and E4. Why these are called slow releasing substance of anaphylaxis? Because it acts like a histamine. It causes bronchodilation, bronchoconstriction, and it causes increased bronchial gland secretion. On the other hand, if we see cyclooxygenase pathway, there are prostaglandin production. So there are certain drugs that blocks these pathways, like cyclooxygenase pathway is inhibited by NSAIDs, but drawback of using NSAIDs in case of bronchial asthma is that when it blocks cyclooxygenase pathway, it shifts the whole pathway towards lipooxygenase pathway, and in return it worsens the asthma. And on the other hand, lipoxygenase pathway can be blocked by using leukotriene antagonist or leukotriene inhibitors, that are zeferlucast and montelukast. And steroids blocks or inhibits this whole arachidonic acid metabolism. So allergic asthma is an inflammatory process, so the treatment should be anti-inflammatory. Bronchodilators that are given to a asthmatic patient are for time being relief. Okay, so intrinsic asthma, as I told you guys, that it is due to autonomic dysfunction, that is due to trauma, ischemia, or some kind of injury to hypothalamus, and in return there is parasympathetic overdrive, and it causes bronchoconstriction. So the drug of choice in case of intrinsic asthma is parasympatholytics, because there is parasympathetic overdrive. So drug must be parasympatholytic, and that is ipratropium bromide. Clinically, patient will present to you with chest tightness, dyspnea, cough, and sputum production that must be white in color, and wheeze. So on examination, when you will examine the patient, there will be tachypnea, that is hyperventilation, there will be tachycardia, there will be bilateral chest movements. Note that unilateral chest movements is due to some kind of injury, and when you will percuss the patient, on percussion it will be resonant note, and on auscultation there will be decreased air entry and bilateral rhonchi. On investigation, you will find out normal chest x-ray, cbc. On cbc you will find eosinophilia. On sputum exam, it will reveal eosinophils, Crushman spirals, and charcoal laden crystals. And serum IgE levels will be increased. On ABGs, partial pressure of oxygen will be decreased, and but partial pressure of carbon dioxide will be normal. And investigation of choice in case of bronchial asthma is pulmonary function test, and that will be FEV1 to FVC ratio will be less than 80%. Thank you so much.